Alright, we're going to talk about hepatic encephalopathy. Specifically, I'm going to cover the pathogenesis and pathophys, look at the clinical features, and then the treatment. Let's start off with what is hepatic encephalopathy. Basically, it's a state of liver failure that leads to central nervous system dysfunction. This list is only a partial list of the possible things that hepatic encephalopathy entails, and after we talk through the pathophysiology of it, you'll be able to make your own list. So imagine that this red circle is your stomach, and over here I have drawn the basic outline of what an amino acid looks like. So imagine right now you're at liver failure and you're eating protein. And so a protein has a carboxy group, and protein also has an amino group, an NH3, and then there's an R group that is variable. So this is the basic structure of an amino acid, and then you know that proteins are made up of many amino acids connected together in a long chain. And so whenever you eat these, your body will cut these into individual amino acids that'll look like this, and they'll be absorbed. The problem is you won't absorb all of the amino acids that you eat. Some of them will make it into the large intestine, where there's a lot of bacteria, and the bacteria will break these off so that you cleave off the amino group and you're left with an NH3 molecule. So here, large intestine, the bacteria are breaking down your amino acids and leaving ammonia. So I went ahead and drew the ammonia that the bacteria are breaking off of the amino acid, and you'll remember that ammonia can combine with a hydrogen ion and form ammonium. If there are lots of hydrogen ions, then you'll form lots of ammonium, and if there are relatively few hydrogen ions, you'll form ammonia. You'll keep the ammonia. Now this is important because the pH, when the pH is low, you have lots of hydrogen ions. You'll have lots of ammonium. Ammonium is positively charged, and positively charged molecules cannot freely move across the membrane. And so it can't go across the cell walls, it can't go into the intestines, you can't absorb it. But whenever you have an alkaline environment, you will absorb the ammonia very easily. Our GI system, after the stomach is very acidic, but after that it becomes alkaline. And so your entire GI system is alkaline, and you'll have the formation of ammonia, which is easily absorbed. After it's absorbed, it goes through the portal system into the liver. And in the liver, that's where it would usually be detoxified. So your liver would take the ammonia, it would combine it into the urea cycle, making urea out of it, and you would urinate it out. However, we know that in hepatic encephalopathy, our liver is not properly functioning, and so we don't have the urea cycle, so we have excess ammonia in the serum and in the blood. Now, I've went through all of this detail to point out two things because these are both areas that are important for the treatment. So the urea cycle not being working properly, you can administer something called L-Ornithine L-aspartate, which can become an intermediate for the urea cycle and help the liver to detoxify the ammonia. Now, the other thing I was pointing out is that if you can acidify the intestinal system, you can trap the ammonia in the GI system and it won't be absorbed. And that's where you use lactulose. So lactulose is a sugar, and you feed it and you won't absorb it. Your GI bacteria will again break that down, and when they break down the lactulose, they form a low pH. They form hydrogen ions. So the lactulose does two things. The first thing is it's an osmotic laxative, and so once you eat it, your bowel movements will increase in frequency. So anything that goes into your mouth will come out your rectum, and that's good because you're going to push all of the extra ammonia out before it's absorbable. But you're also going to create an acidic environment, so anything that could possibly be absorbed will be trapped. There are two other aspects of the pathophysiology that can be targeted. For example, you realize quickly that if you have no protein available, then you cannot form the ammonium. On the other hand, you also realize that if you have no bacteria there will be no conversion. Early on in the treatment of hepatic encephalopathy, what physicians would do is they would put patients on a low-protein diet, and in that low protein diet, they would come out of their hepatic coma in some situations and be stable for the most part. However, in the long term, they tend to do less well because muscle is one of the primary storage sites for ammonia. And so if you don't eat enough protein, you start losing muscle, you start breaking down muscle, and you have less storage for the excess ammonia. And so something that has been found to work is to switch from a primarily animal-based protein diet to a very plant-based protein diet. Part of why that works is because you will have enough fiber to push the excess protein through before it can be converted into ammonia and absorbed into the blood. Other possible treatments is that you could take the antibiotics that will destroy the bacteria in the colon. There's some controversies on which antibiotics should be used to do that. Right now, the number one first-line treatment in that situation is rifaximin, but you can also use neomycin, you can also use oral vancomycin, and metronidazole. The one you should remember is rifaximin at this time. Now what's going to happen is once the NH4 gets past the liver, it's going to go to the brain. But the brain has a protective mechanism, that's called an astrocyte. So instead of getting into the brain, the astrocyte will absorb the NH3, it will combine it with glutamate. Via the enzyme glutamine synthetase, it will form glutamine. This takes care of the issue of having the excess ammonia. However, it doesn't take care of the problem of having excess glutamine and too little glutamate. And just by way of review, what we said is that you have GI bacteria that will produce ammonia from your dietary protein. This ammonia is in an equilibrium, NH3 and NH4. The liver will fail to detoxify the ammonia, and because the urea cycle is all processed by the liver and the liver is failing. Therefore, the astrocytes attempt to detoxify the substance, and the reason that it does that is because it can be a direct toxin to the neurons. What ultimately happens as the astrocytes detoxify the ammonia, it reduces key neurotransmitters. This ultimately leads to an increased intracranial pressure, and that is due to some of it is due to osmotic pressure, some of it is due to an increased cerebral blood flow. And what I mean by that is the cerebral vasculature can no longer regulate itself. And then the last thing is we get altered microglial activity. Let's pause and take a look back at the biochemistry. So what I've went ahead and drawn here is I have an excitatory neuron, an inhibitory neuron, and in the middle I have this astrocyte. Now you'll know that glutamine can come from two different areas. So you can form glutamine directly from glucose and ammonia. The other possibility is that you recycle your glutamine. So because you want to use your glucose for energy and other things, if you are using glutamine, you can recycle it. And so there's two different cycles. There's the cycle that starts from glucose and goes up to glutamine and then forms the neurotransmitters. So let's look at that really quick. We have glucose that goes into the citric acid cycle. The citric acid cycle forms alpha-ketoglutaramate. Alpha-ketoglutaramate is combined with NH3 to form glutamate. Glutamine synthetase forms glutamine with another ammonia. This is all occurring in the astrocyte. Now, some of this can occur inside of the neurons as well, but for the most part, we're going to say this is occurring in the astrocyte, and the glutamine is formed. Once the glutamine is formed, it goes from the astrocyte and gets exported to the neuron. So the inhibitory neuron will take that glutamine via glutaminase, release an NH3 to form glutamate, then glutamate decarboxylase to release some CO2 to form GABA. And GABA is our inhibitory neurotransmitter. In the excitatory neuron, the only thing you have is the glutaminase, same as over here, to form glutamate, and glutamate is our excitatory neurotransmitter. If that was the end of the story, then we would be using a lot of glucose to make our neurotransmitters. Fortunately, there's this second way, and so what we have is this recycling. Once the excitatory neuron releases the glutamate and it has its activity, most of that glutamate gets reuptaken by the astrocyte. The astrocyte will then combine it with NH3 to form glutamine again, and that glutamine can then be exported. Things are a little bit different with the inhibitory neuron. It releases GABA, and GABA has actually three fates. So whereas glutamate, 90% of it would be taken up by the astrocyte, only a relatively small amount of GABA will be taken up by the astrocyte, and the rest of it will be recycled back into the inhibitory neuron, or it can also be broken down. Once it's reuptaken by the astrocyte, several steps to form succinate, several more steps back to glutamate, and then we go through the cycle again. Now, if you have an excess of NH3 or NH4, if you have an excess of that, then there's a couple things that can happen. One thing is you can do less deaminating of glutamine, or you can form more glutamine. And so that's what's going to happen is your astrocytes are going to take up the excess NH3 and use up glutamate to form glutamine. So you'll remember that glutamate, 90% of the excitatory neurons are going to send their glutamate back into the astrocyte. And so you're going to have a whole bunch of this glutamate being sequestered in the form of glutamine. Some of the GABA will also be taken back up and be sequestered in the form of glutamine as well. Now you can see how this might cause some problems. So we have this balancing act that our brain does. It sends out enough excitement and enough inhibition. It sends out enough excitement to keep us awake and keep us going. It sends out enough inhibitory command to keep us from going into convulsions. And because we're sequestering up this excitement and inhibition inside of the astrocytes in the form of glutamine, we're sequestering it all up, we can have a defect in either direction. Typically, we'll have a defect where we'll lose excitement and become, comatose. Or the other possibility is that you can lose inhibition and become anxious. Both of those things happen in hepatic encephalopathy. Let's talk about the implications this has for pharmacology. So over here on the left, let's imagine that this is my excitatory neurotransmitters, and over here these are my inhibitory neurotransmitters. They are basically in balance. So if I were to do something that added a little bit of extra excitement, it still wouldn't change the balance that much. And likewise, if I were to add something that had a little bit more inhibition, it still wouldn't change the balance that much. But as soon as I cause both of these things to shrink, anything that I add to either side is going to have a larger impact. So let's suppose I shrink the inhibitory side a little bit more than everything else. It's not much smaller, but it is smaller. And so now I have way too much excitement. I'm anxious. I have anxiety. And so I add, a little medicine over here. All of a sudden, I have put myself into a coma. We'll call this medicine a benzodiazepine. And I'm saying this because with hepatic encephalopathy in the early stages, you can go both ways. You can go to the balance being overly excited or overly inhibited, somnolence or crankiness. Okay, so now I've showed that we have a disruption in the balance of neurotransmitters, but the other thing you need to know is that when we have excess glutamine, this in and of itself causes other problems. The first thing it can do is it can become an osmole, and that will cause swelling. The second thing that it can do is that it can reduce the vascular autoregulation. And the reduced vascular autoregulation is going to cause increase in blood flow. The increase in blood flow is going to have two outcomes. The first is you're going to get more delivery of NH4, but that's very minor, just bringing a full circle. But the other thing is with reduced vascular autoregulation, increased blood flow, you have increased cerebral pressure. You'll remember back in your neurology, block 3, that we discussed how the total volume inside the cranium, because the cranium is a hard fixed space, it can hold the brain, it can hold CSF, and it can hold blood. If you increase any one of those things, the pressure increases. And so now we have two things that are increasing the pressure inside the head. And now lastly, indirectly, we have glutamine carrying NH4 into the mitochondria. So here I'm going to draw my little mitochondria, kind of looks like a bean or something. And it goes into the mitochondria, it releases NH4 or NH3 to become glutamate, and it leaves back out as glutamate. But this NH3 inside the mitochondria, it does two things. So it's going to reduce oxygen consumption, And the reduced oxygen consumption is due to the fact that it is a mitochondrial toxin. This is specifically called the Trojan Horse hypothesis. Now, the brain needs energy, and so if the mitochondria are being destroyed, we're getting less ATP, and so you have to increase glucose intake, glucose consumption. With increased glucose consumption and decreased O2 consumption, you're going to get an increase in lactate. Now we get to the point where lactate has two paths it can take. The first path is that it's going to stimulate tachypnea, and this will result in a respiratory alkalosis. The second thing it does is studies have shown, this is still initial, basic science study stuff, and we're not sure how much it has to do with the actual pathophysiology, but the second thing is that lactate causes astrocytes to swell. So the astrocytic swelling, that's going to further complicate cerebral edema. I said that the tachypnea will result in an alkalosis. This is bad, but it might have some good too. There are pros and cons. And the pro is, with alkalosis, you get vasoconstriction, cerebrovascular vasoconstriction. So you might actually reduce some of that excess blood flow going to the brain. Okay, by way of review, we know that the astrocytes want to get rid of the ammonia to protect the neurons, and by doing that, they form glutamine via glutamine synthase, and that causes a loss of glutamate, a loss of GABA, it causes an excess of glutamine, and then any excess of NH4 is going to be directly neurotoxic. I've put down here a little reminder. It's not extremely important, but because you might want to look it up or Google it, there are two different cycles that I talked about. The first one is the glutamate-glutamine cycle, which is producing the new glutamine and new GABA from glucose. The other is the glutamate-GABA-glutamine cycle, which means the recycling of the neurotransmitters. I'll remind you that NH4 is directly toxic to the brain and to neurons, and so what it can do is it will cause mitochondrial damage, it reduces O2 consumption, it increases glucose utilization. All these things combined lead to excess lactate production, and it can also do some things to damage the blood-brain barrier. Ultimately, so far, I've only been talking about what NH4 is doing. We know that the liver detoxifies the entire body of several things, including ammonia. And so we know mostly about what the ammonia is doing to the brain. There are so many other toxins that are going to be in excess because of liver failure, and now they are going to be able to have access to the brain via the decreased blood-brain barrier. There are also a lot of evidence that NH4 can act directly on the brain on several receptors, acting both as an excitatory and an inhibitory neurotransmitter. So this is a good time to talk about GABA. First, the GABA receptors, the GABA-A specifically. Remember that GABA-A is made up of 5 subunits. So let me go ahead and draw those out. We have our 5 subunits. And if we zoom in on those subunits, we can see that we have a gamma subunit here, an alpha, a beta, an alpha, and a beta. Now this is sort of a top-down view, because you'll know also that let's go ahead and draw our cell membrane here. So we have a cell membrane, and in that cell membrane we have a GABA receptor, and that's sort of like an ion channel. So this is my GABA channel. And at the microscopic level, what you'll know is that each of these subunits, for example, the gamma subunit is like a long rod that makes up sort of part of a tube. And then you would have your alpha subunit, and over here you would have a beta subunit, and another alpha, and another beta, and altogether you would have an ion channel. GABA itself acts on the alpha and beta subunits. Benzodiazepines, on the other hand, will bind to the alpha and gamma subunits, and barbiturates will bind to the beta and gamma subunits. Now let's just assume there are no benzodiazepines and no barbiturates in question. So the GABA will bind to its receptor, and when it does, chloride ions will be able to move into the cell and hyperpolarize it. If we look at this as the cell overall, as the cell potential, we draw a graph here. Let's say that this is our threshold potential. Normally we would sit about right here, and then if we had a GABA channel open, it would drop down and it would come back up. If we had an excitatory channel open, it could come up, hit the threshold, and then go on to send out an action potential down the axon. The overall effect of benzodiazepines is that they will cause the GABA channel to be set off more often. Whereas the overall effect of the barbiturates is that the barbiturates will cause the GABA channels to stay open for a longer period of time. Now let's go back and look at the channel itself, because there is some preclinical evidence that NH4 can it will bind to the benzodiazepine binding site. And so there's some thought that in hepatic encephalopathy, NH4 is binding to this site and that we can reverse its activity by giving a drug called flumazenil. Flumazenil will actually come to this specific site and block it so that it can have no activity. It doesn't increase the effect of GABA, it doesn't decrease the effect of GABA, it just keeps the effect of GABA normal. The problem with these studies is that several of the people who were involved in the original study where flumazenil was administered, they were already taking a benzodiazepine, because you'll know whenever the beginning stages of hepatic encephalopathy, people get cranky and irritable, and so they take a benzodiazepine to help them calm down. So several people who have hepatic encephalopathy are taking a benzodiazepine, and so whether or not the flumazenil was blocking the benzodiazepine or the NH4 was not able to be detected. A systematic review of 12 clinical trials using flumazenil has found that there's probably some improvement in some of the patients, but there is no change in overall outcomes, and so at the present time, the treatment with flumazenil is not recommended. And we said that we get an increase in glutamine that reduces the available glutamate and GABA. Ultimately, this is going to alter cerebral blood flow and change the oncotic pressure, both of those leading to edema. And I already mentioned that there's this other theory that glutamine will shuttle NH4 into the mitochondria, and it'll become a toxin there. That's called the Trojan Horse hypothesis. Another theory that I didn't mention is that glutamine will transaminate into alpha-ketoglutaramate, and alpha-ketoglutaramate will act as a neurotoxin. Due to the mitochondrial damage, we get an increase in glucose consumption, a decrease in O2 consumption that results in lactic acidosis. And this will cause the astrocytes to swell. It'll also cause tachypnea, resulting in respiratory alkalosis. Now, this is something that I didn't present in the big unified drawing, and that is that we get a change in microglial activity. The exact mechanism of this is not completely known. But the cytokine profile from the microglia will have damage to the CNS, and it will also alter the blood-brain barrier. So in the future, this will probably become more and more important in the pathophysiology of hepatic encephalopathy. Okay, now we're going to switch gears really quick. We've been talking about the pathogenesis and pathophysiology. Now we're going to talk about the physical exam. You may have heard of the word asterixis. Asterixis is a common finding in people with liver failure. It comes from the Greek word sterix, which means a fixed position, and it has the negative particle a. So asterixis means no fixed position. And this refers to if you had somebody standing with their arms out and their hands sticking straight up, you would periodically see their hands flap down and then flap back up for no apparent reason. It's important to keep in mind that asterixis, although it's a common physical exam finding and a really, really useful clue, it is not used at all in the scoring system for hepatic encephalopathy. So what we're going to talk about is something called the West Haven scoring criteria. And the West Haven scoring criteria will put somebody into one of a few actual scoring categories. We can talk about those categories qualitatively as either being covert, early, moderate, or late. And this may actually be helpful. A recent article in the New England Journal of Medicine took this approach where it tried to describe hepatic encephalopathy going through progressive stages. And what you should know is if you don't have any inclination of liver failure, detecting the covert stage is going to be nearly impossible. However, if you do have suspicion of hepatic failure, then you're going to have to be able to differentiate the covert stage from other causes of liver failure. So, for example, the covert stage, you get frequent falls, impaired driving, distraction, disinterest. This also looks very, very much like alcoholic intoxication. And then when we're looking at the early stage, what's important to keep in mind is that you can follow one of two paths. You can either go to a path of excess excitability or excess inhibition. So the excess excitability might look like things like irritability and anxiety, where the excess inhibition might look like things like tiredness, yawning, or dozing off. In this early stage, you're going to have a preserved pupillary response. This is the important distinction between an early and moderate if you're looking at it qualitatively. Qualitatively, in the moderate stage, you have a sluggish pupillary response, and in the late stage, you have a loss of pupillary response, and this is due to the cerebral edema. And I said you can go through this increased excitatory phase or increased inhibitory phase. This continues in the moderate stage because you can have this unrest or you can have this loss of orientation. What's important to remember, the key finding here is that you have the lack of memory and you have the 4 R's, the registration, retention, and recall. You might have noticed that that's only 3 R's, and I add the 4th R because of repetitive picking. Understanding hepatic encephalopathy qualitatively is helpful, but ultimately, whenever you find somebody in this condition, you have to grade it using the West Haven scoring criteria. And you can see right here, grade 0 is not really going to be detectable. On grade 1, you want to find impaired calculation, and on grade 2, inappropriate behavior. Grade 3 is going to have bizarre behavior. So this is the West Haven scoring criteria altogether, and I've also listed here that there's something else called the 4-score criteria, and what the difference between the West Haven and the 4-score, the West Haven scoring criteria goes all the way through the stages of hepatic encephalopathy up to the coma. Once you get to the coma, the 4-score breaks this down into the different aspects of your activity, whether you have an eye response, whether you have a motor response, etc. And so it breaks all of those things down, whether you have a breathing response. And you can use the 4-score to determine management of a person once they've entered into the coma. Here again is the breakdown of the West Haven scoring criteria. You'll remember that you have impaired calculation, inappropriate behavior, bizarre behavior. Knowing the differential of all of this is very important because there are a lot of mimics of hepatic encephalopathy. First of all, with Wernicke-Korsakoff, because of the amnesia and the memory loss you get with hepatic encephalopathy, the way you can remember this, though, is that with Wernicke-Korsakoff, you get confabulations. This is where you can ask a person any kind of ridiculous question you want, and they will give you an answer, and they will believe their answer. They'll make it up on the spot, and this is a key finding in Wernicke-Korsakoff. You'll also remember that Wernicke-Korsakoff has specific ophthalmological findings as well. With alcohol withdrawal, because you can have that tremor and everything, and that increased irritability, excitement, you might confuse that, but you'll want to remember that these tremors are rhythmic and coarse, and you'll remember that they also have a dysautonomia, cold sweats. Now, non-convulsive status epilepticus, this seems like a pigeonhole type of thing to think about, but there's more and more use of EEG in looking at the stages of hepatic encephalopathy, and EEG on both of those will show a triphasic pattern. It also, you'll have altered consciousness, and you can have automatisms, and so that's why you'll want to get a neurologist or an expert in reading EEGs to be able to distinguish these two if there's ever any doubt. Lastly, a subdural hematoma. You remember that the compression can cause a global decrease in mental status, mental function, but you should also be able to find focal neurologic signs with a subdural hematoma, whereas you would not in hepatic encephalopathy. I just mentioned how EEG is useful in working up hepatic encephalopathy, especially if you have any doubts. And so I'll just walk through this really quick. First of all, in stage 0, something that is extremely sensitive for detecting hepatic encephalopathy is called brainstem evoked potential. So your electrophysiology is important here. On grade 2 through 3, you start getting that triphasic pattern, and I remember reminding you that it can be confused with non-convulsive status epilepticus. Now, if you're studying the liver failure all at the same time, you're going to hear about a lot of different scoring systems. I'm going to break these down for you really quick. West Haven scoring system, this is how severe is the encephalopathy. The 4 score is how severe is the coma of the encephalopathy. Then there's the MELD score and the child score. This is also called the Child-Turcotte-Pugh, or just the Child-Pugh, or the CTP. It's got a lot of different names. This score has some usefulness in determining how a person will respond to various things. This used to be the score that was used to determine if they needed a liver transplant or if they were eligible for a liver transplant. For the most part, the child score has been replaced with the MELD score. Now, I say that, I want to say that there are still people that argue for clinical utility of the child score, and so I don't discourage you from looking into it and learning it. And in fact, right here is the child score. I want to say that I got this table from Wikipedia. But you look at what goes into the child score: the bilirubin, the albumin, the protime, the ascites. And some people will replace protime with the INR. And then you can grade the hepatic encephalopathy, and this grading system uses the West Haven scoring system. Each one of these things, you can get 1, 2, or 3 points, and then you look at the point system down here to see what their overall survival was. There was a correlation between the points and the survival, but the correlation was not as strong as it needed to be to predict liver transplant. And so for the most part, this was replaced with the MELD score, and we'll come back to the MELD score in a moment. Okay, so now in the treatment, we'll look at the therapeutic strategies. The main therapeutic strategy is to lower the ammonia levels, followed by correcting any electrolyte abnormalities. There is some evidence that mild hypothermia may be helpful. There's no guidelines on this yet, so keep on the lookout for that. There's also some evidence that N-acetylcysteine will help. It's potentially beneficial in hepatic failure, whether or not it was caused by an acetaminophen overdose. Also, with hepatic encephalopathy, it's an inflammatory problem as much as it is other things, and so treatment with minocycline has been recommended. This is sort of a bit controversial and not recommended first or second line anywhere, but you may consider it whenever other treatments fail. In the future, there may be a role for memantine and flumazenil, so keep your eye out for that. And there also may be a role for L-carnitine, so those are sort of things that are in trial at the moment. So following our therapeutic strategy, our first-line treatments at this current time in history, lactulose and lactolol, these are sugars that are going to be osmotic laxatives. So the main thing this will do is it will create an acidic intestinal environment, and the acidic intestinal environment will favor the conversion of NH3 into NH4, and NH4 is a positively charged cation. It cannot be absorbed. The two secondary effects it's going to have, first of all, is going to cause the volume of the stool to be increased. This increase in transit will prevent some of the NH3 that wasn't converted. It will prevent it from being absorbed because it will be pushed out faster. And another effect is that you will favor an environment of bacteria that are glycolytic rather than proteolytic. You, in essence, will allow for the out-competing of the proteolytic bacteria, getting rid of some of them. So it would not be fair if I did not mention that trials have been done showing that polyethylene glycol is probably just as good as lactulose. There's also a study done in India that showed that lactobacilli plus bifidobacteria plus streptococcus thermophilus, those three combined, whenever they were given as probiotics, they could also help in the treatment of hepatic encephalopathy. Then one choice of treatment if your patient has diabetes may be acarbose. So acarbose will actually block your alpha-glucosidases in your small intestine so that you'll get all of your glucose into the large intestine, and it will have the same effect as lactulose. So I think it's also important to point out, so we have talked about we're going to reduce the blood ammonia, but how did the ammonia get there in the first place? It was through some source of protein. Now protein typically, almost most of the time, comes from what we eat, and we don't want to decrease our protein intake, but sometimes the excess protein comes from gastrointestinal bleeding. So this is something important to look for in a person who has hepatic encephalopathy. Now, I'll also mention rifaximin. Several studies have shown that rifaximin, even by itself, is equally as effective as lactulose. And when rifaximin and lactulose are combined, it is better than lactulose on its own. Rifaximin is essentially an antibiotic that's going to go in and destroy the proteolytic bacteria. In the past, neomycin was used. It's no longer recommended. What you can try is oral vancomycin and metronidazole. Those are effective, but they're not recommended as first line. So far, we've talked all about things that can prevent the NH3 and NH4 from being brought up into the body. But if you think about it, there's a couple of possible avenues in the treatment. So we can stop it from being absorbed, we can stop it from having a systemic effect, or we can increase its excretion. And that's where L-Ornithine, L-aspartate, and a new kid on the block, sodium benzoate, that's where they have their therapeutic effect, is causing an increase in loss. Now let me remind you of the urea cycle. So the first step in the urea cycle is that ammonium and bicarb combine to form carbamoyl phosphate. Then the second step is that carbamoyl phosphate has to combine with ornithine. This will form citrulline. Then citrulline has to combine with aspartate to form argininosuccinate. The argininosuccinate will break down into arginine and fumarate. And then if everything works out right, the arginine will form urea and get returned back into ornithine. But you know that every cycle is concentration dependent. So if I have a liver that is failing and it has a little bit of an ornithine concentration, but not much, I can drive this reaction forward by adding more ornithine. And I can drive this reaction forward by adding more aspartate. And so I can add L-ornithine, L-aspartate, sometimes called LOLA, and I can drive the urea cycle a little bit faster. Another option is something called sodium benzoate. So sodium benzoate basically looks like this. It has a phenyl ring and a carboxylic acid. It will combine with coenzyme A to form an intermediate. Then it will release the coenzyme A and bind with glycine. And when it forms with glycine, it forms this compound, and you can see that we've added a nitrogen group to it. This compound is hippurate, and it's soluble, and you can urinate it out, so it's a way to get rid of nitrogen through your urine. Right now, this is sort of under clinical investigation. It's not recommended as a treatment at this time. So we've covered blocking ammonia getting in, we've covered increasing ammonia getting out. We haven't talked about altering the internal effect. That's where there has been a big push for increasing the treatment with branched-chain amino acids. It's thought that the phenol amino acids have an increased ratio during hepatic encephalopathy, and so that treatment with branched-chain amino acids can restore the appropriate ratio, and studies done with this have shown a reduced harm from people who took branched-chain amino acids, and so it has been a recommendation in the diet along with plant-based proteins. When there is no response to the standard treatment, you have to ask yourself what is wrong, and so you might start thinking about portosystemic shunts. Allow me to explain what I'm talking about. So pretend we have our liver here, and then over here we have, for example, the spleen. Below the spleen we'll have the kidney. And then we'll make this other big amalgam and we'll call it the GI system, going from the stomach all the way down to the large colon. Now we know that we have the portal vein coming from the GI system at several different points, and everything comes into the portal vein. And you also have the spleen feeding into the portal vein. This is really important. Now, as far as everything else in the body, the veins go to this inferior vena cava. Now, it's important, I should probably draw this a little bit differently, a different color, is that the inferior vena cava does not interact directly with the portal system. It's sort of behind the portal system. But the kidney feeds into the inferior vena cava. When the pressure in the portal system gets too high, it will start to expand and swell. And as it swells, that splenic vein can anastomose with the renal vein. And when it anastomoses with the renal vein, then you'll have this portal blood that will go from the various portions of the colon, and it will go into the systemic circulation into the inferior vena cava. So this is a portosystemic shunt. This is not the same kind of portosystemic shunt that you get with a TIPS procedure. A TIPS procedure is a surgical procedure that is used to treat portal hypertension. And otherwise, this is a portosystemic shunt that is caused by portal hypertension. The problem with that is that we have excess NH4 being produced in the colon, and it would go into the liver, and some of it, a very small amount of it at least, would be detoxified into the urea cycle. However, now, instead of being detoxified by the liver, it's going down through the splenic vein, into the renal vein, and up through the inferior vena cava. None of it is being detoxified. It's going directly into systemic circulation. So if you are not getting a response from the main treatments, you have to consider a portosystemic shunt, and possibly even just correcting that could make it better. However, correcting it could also cause things to get worse because you have the portal hypertension that caused it, and it's going to cause the portal hypertension to worsen. So the first and second line treatments is looking for a systemic shunt. The second part of treatment, refractory treatment, is liver transplantation. And so liver transplantation is determined by using the MELD score and the sodium level. And as recently as about 1 year ago, the name of it changed to become the MELD-NA. The MELD-NA, or the MELD sodium score, so it's all combined now. However, let's take a look at it. It's not important to know this formula, this calculation. What's important to know is what goes into the calculation, the bilirubin. So I want to know how well my liver is functioning. Is the liver able to take the byproducts from dead blood cells and get rid of it appropriately? The INR, is the liver's function in synthesizing clotting proteins, is that still working? Is the liver still making the things it's supposed to make? The creatinine, when the liver starts to fail, it can also cause the kidney to fail. This is called hepatorenal syndrome. And so you can get a MELD score that ranges between 6 and 40. And the higher the score, the more severe the disease. Anything over 15, you can get put on a liver transplantation list. So ultimately, you take your MELD score, whatever you calculate it as, and you combine it into this MELD sodium score, and you can use that to predict mortality. This is just for your reference. You don't need to know how to calculate these things. In fact, you want to use MD-Calc anytime you go to calculate the score, because there are so many exceptions to the rule. For example, if your creatinine is over 4, you have to round it down to 4. On the other hand, if your creatinine is under 4, but you have had dialysis twice in the last week, you have to round the creatinine up to 4. And so with all of the exceptions to all the rules, you should just always use MD-Calc. You should never try to memorize this calculation. The last thing in the therapeutic strategy is managing the symptoms. So you have all your symptoms of liver failure, and then you have your intracranial pressure. Your goal is to reduce the intracranial pressure to less than 20 millimeters of mercury. You want to limit your cerebral perfusion pressure to 50 to 70 millimeters of mercury. And things that you can think about doing is just elevate the bed by 30 degrees. You can prevent ventilator desynchrony. So if your ventilator is breathing at a different rate than than what the person wants to breathe, that can increase intracranial pressure. Another thing that you can do is you can induce hypocapnia. This will alkalinize the CSF and it will reduce cerebral blood flow. If the intracranial pressure rises too high, hypertonic saline and mannitol can be considered, and then renal replacement therapy, basically dialysis, is also recommended based on the nephrologist's recommendation. These are a few of the sources I used. I would encourage anyone to read the new review article by the New England Journal of Medicine.